Tuesday, June 15th to order. Please stand and join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. All right. Doreen, roll call, please.
Amo.
Here.
Anagnostakis.
Present.
Lujan. Sutherland.
Sorry,
Here.
present.
Tortel.
Here.
Dewey.
Here.
O'Donnell.
Here.
All present.
Thank you. Item number one is Commissioner Darcy Miller with the monthly update of Department of Mental Health. So you're on, Darcy.
Good afternoon, Chairman O'Donnell. So I think probably the most significant thing to report that's new is that the Project HOPE, which is the SAMHSA-funded New York State project supporting families who have struggled with mental health challenges throughout the pandemic, free of charge, providing services through Mental Health Association, Access Supports for Living, Independent Living, has gotten a no-cost extension through December of this year. Knowing the increased need throughout our community, the increased number of presentation of young people in our local emergency rooms, the demand for hospital beds, and the outpatient access demands, we're very appreciative of how this extended support can help to fill some of that gap while people begin to stabilize emotionally through the impact of the pandemic. We continue to work very closely to address overdoses related to opioids and have had some success. We appreciate the Department of Health support in that project. We're looking to expand to include Garnet Health in that project and have them participate for those who present in emergency rooms, and we look forward to their expanded partnership with our community services, as it's imperative that we work together to have a smooth, seamless continuum response. Additionally, telehealth, thank you. Telehealth has been supported, will continue to be supported beyond the pandemic. We are moving forward with face-to-face visits and have seen some increase in that area, and appreciate all of our behavioral health providers who've assisted in providing stabilization. I will say that one area where we will continue to try to address is expanding accessibility for law enforcement to be able to co-respond with mental health providers. We have struggled. There was a recent court decision made that's impact how we work with our mobile response team. We also have heard clearly from law enforcement that they would like to be able to have a more expedient response from mobile teams. And we'll try to sort out how we can make that happen throughout the county, knowing that co-responding in many circumstances is the best way to address crisis that's happening in our community. And that's it. You're muted, Chairman O'Donnell.
Thanks, Commissioner. I'm looking for any questions. I don't see any from any committee members. Anybody out there, Doreen?
I don't see anyone.
I don't see any. So thank you very much, Commissioner. Appreciate the update. Thank you. Item number 2 is Commissioner of Health. And 2A is a request to accept and appropriate funds into the operating budget for the New York State Department of Health for the Public Health Emergency Preparedness Program grant for the period 7/1/21 through 6/30/22 in the amount of $237,306. Legislative request number 108. Do I have a motion?
So
moved. All right, Legislator Tui and Legislator Sutherland, thank you. Go ahead, Commissioner.
Good evening, everyone. Thank you, Mr. Chairman. My Deputy Commissioner, Chris Erickson, will walk us through the funding appropriation, and then I'll give the monthly update. Thank you.
Sure. Okay.
So Chairman O'Donnell, so this is the Public Health Emergency Preparedness Program, the grants, the fund for that, which has been going on for many years. Interestingly enough, a lot of these funds were used for situations like this year with the pandemic and for planning and for the training that happened that really ended us up in a really good place with the response for that. So this goes to support a staff person and a couple contractors and supplies for that program.
Okay. See Legislator Tortel?
Yes, Mr. Chairman, could you please add me to this?
Certainly.
Thank you.
I don't see anyone else. So all in favor?
Aye.
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 Any opposed?
Bless you.
Bless you.
Thank you.
Gesundheit.
Okay, carried. 2B, request to accept and appropriate fourth-year funds into the operating budget for the New York State Department of Health Immunization Action Program for the period 4/1/21 through 3/31/22 in the amount of $189,605. Legislative request number 101. Do I have a motion?
So moved.
So move, Luhan.
Second.
Tui.
Legislator Luan and Tui. Thank you. Go ahead, Deputy Commissioner.
Yep. So again, this is a long-standing grant. This is the fourth year of a 5-year contract with this. The purpose of this is under the contract, the local health department will conduct assessments, outreach, and conduct activities to increase childhood, adolescent, and adult immunization rates to reduce the occurrence of vaccine-preventable diseases. This does support a secretary in the position and also some employee chargebacks for other nurses that are working in that program.
Okay. Any questions from committee members? Legislator Tortel?
Yes, please add me to this one. Actually, if you could add me to all items through E,
A, B, C, D, E?
please. Thank you.
You got that, Doreen? Okay.
I do.
All in favor?
Aye.
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 Aye. Against? Carried. 2C, request to accept and appropriate fourth-year funds into the operating budget for the Adolescent Tobacco Use Prevention Act grant from the New York State Department of Health for the period 4/1/21 through 3/31/22 in the amount of $97,198. Legislative request number 087. Do I have a motion?
So move, Luhan.
Sutherland.
All right, so Legislator Lujan and Legislator Sutherland, thank you. Go ahead, Deputy Commissioner.
Yes, Mr. Chairman. So this is the Adolescent Tobacco Use Prevention Act, otherwise known as ATUPA. The ATUPA program prohibits the sale of cigarettes, cigars, chewing tobacco, powdered tobacco, other tobacco products, electronic cigarettes, liquid nicotine, all those types of things from being sold to persons under the age of 21. The Orange County Department of Health is responsible for enforcing ATUPA, which includes conducting unannounced compliance checks of retail tobacco dealers, also known as the retailers, and vendors, and retail vapor products dealers and vendors using underage. We use underage youth to actually do some of these operations and seeing if they will sell to us. So this program, again, has been going on for a while. And again, we're happy that this program continues and that we have funding for it.
Okay. Any questions for the Deputy Commissioner? Legislator Tui.
Yeah, Chris, I just, I'm looking at the Schedule A, and it looks like we have a base salary. It's one person, youth compliance workers, fringe benefits. Or is there any other kind of outreach to motion or advertising that's done to attract, to target youths and anti-smoking, no smoking, or is it all administrative?
No, I mean, there's educational materials that are generated. The positions here that you look at, like permanent base salary, that's essentially half of a person and like 4/10 of another person. So some of the staff that are in these positions are also working in other grants that mingle very well with them. So they're community health outreach workers or public health educators that work not only in this program, but work in other programs. The youth compliance worker part there, that is what is paid to the teenagers that go out and do the sting operations with us, so that's like their hourly rate. So yes, there are other parts here of our education that are included not only in this program, but our other community health outreach programs is with our health and wellness programs with regard to smoking and the enforcement of that.
And the youth compliance workers, that's it's not a big number. It's $2,492. How many
Yes.
workers does that actually cover and duration of time of being out on the street?
Yeah, it's not that much, quite honestly. I don't know how many we have contracted right now. Typically, we have a couple, 2 or 3, teenagers that are working, for us a couple hours, every other week or something like that when we go out and do these types of operations.
Okay, and then you did mention before about educational and outreach promotion. Where is that? Where are those funds for those materials coming from? I don't see them anywhere here. Where would that be picked up?
It doesn't necessarily have to show up in this program. It could be picked up in our Healthy Neighborhoods program. So we don't have to use the funding directly from this program because it's not a lot of funds to begin with. So we don't have to use the funds from this program to necessarily do any types of public health outreach. It's covered under a blanket.
Yeah, I just asked because I really haven't seen anything over the years.
Okay.
All right. If you can let us know what kind of outreach we're doing, that'd be great. Thank you, Chairman.
Yep.
Mr. Chairman, you're muted.
By my computer. Doesn't like to hear me either. So, Deputy Commissioner, about how many sting operations do we do? How much in fine money do we collect?
Yep. So I don't know what we have right now. I just talked to them the other day. They went out on 3 or 4 compliance checks last week, matter of fact, and actually all of those facilities were doing well. So, we've been doing this program for a bunch of years, and the good news is that less and less places are selling cigarettes and tobacco-related products to minors. So that's the good news. We haven't had a hearing in a while, from my understanding. So, this program is more based, it's not based so much on the educational parts of smoking is bad, right? But this is the enforcement end of it. And the enforcement end of it is doing a good job as far as, making sure that people have the proper signage up, that the operators know that who they can't sell to. And we're checking that on a regular basis, but I don't have any specific numbers for you today as far as what we had last year with with tobacco sales, but the numbers are definitely going down just from what I heard last week.
Okay, I forgot about the hearing part about that. So who's doing the hearings now?
So here, if any types of hearings that would happen with the Department of Health, those would happen internally. So we have someone who is on contract, a hearing officer, that they would, and that goes for any type of violation to public health law, that they would come in to hear, and a hearing officer would hear their objections or hear what the case was.
So is that like a retired judge? I just remember that was an issue back when I was deputy county exec.
It can be. I mean, in the past, we've had retired judges. We've had lawyers from, just working in the community. So, yeah.
Right. Okay. And we only have one person now because we don't have that many hearings?
No, yeah, we just have one person.
Okay, good enough. All in favor?
Aye.
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 Opposed? Carried. 2D is a request to accept and appropriate funds from the New York State Department of Health for the Creating Healthy Schools and Communities Grant for the period 6/1/21 through 5/31/22 in the amount of $305,000. Legislative request number 102. Do I have a motion?
So move Luhan.
I'll second it, Doreen. Thank you. Go ahead, Deputy Commissioner.
Yeah, we're very excited about this program that they released the funds again for this. We had just found out on May 18th or May 19th that we got awarded this. So we're very excited because we've done this in the past also. In general, the Healthy Schools and Communities grant is a New York State Department of Health funded initiative. It's committed to helping build healthier communities with the goal of creating a safer, stronger, and healthy county. Orange County Health Department's Orange County Schools and Communities program has been a partner with Port Jervis Schools, Middletown Schools, and the Newburgh School District in creating different types of work plans for a healthier atmosphere with them. The team has worked with municipal officials as well to encourage sidewalks, bike lanes, and crosswalks known as complete streets. So in this program also, we have, as part of our budget here, is that we also work with the planning department and help fund a person in that unit to work with us in developing programs that work well around school communities and with the deliverables that we have to meet.
Questions? All in favor?
Aye.
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 Opposed? Carried. Item 2E, request supplemental appropriation to the capital projects budget in the amount of $2 million. Funds are for the contracting of a construction management company for the oversight of construction of a medical examiner's building. Proposed capital project number 73. It's bonding. Legislative request number 093. Do I have a motion?
Tui, so moved.
So move Luhan.
Second.
Legislator Tui and Luhan, thank you. Go ahead, Deputy Commissioner.
Yes, Mr. Chairman. So as is no secret, we've been working actively with the planning, the construction of a new medical examiner's facility. This is part of the next step of getting a construction management company to do some of the oversight of that medical examiner's building and the construction of it. So we have been meeting with the architect for several weeks now, and I think we've had 4 or 5 meetings. We're moving along nicely on that. And so we want to put out an RFP, or DPW wants to put out an RFP for a construction management company that will really take this by the horns and oversee the construction of it.
So when will that RFP go out?
I don't know the exact date on it, but typically we get the funds approved first, and then we put out an RFP.
Leader Amo.
Yes, add my name to that, please, Mr. Chairman.
Will do. Legislator Tui.
Thank you, Chairman. Deputy Commissioner, with the, can you give us an update just since you've had these recent meetings as far as, a broad view of location update, what's going on there, and what will be housed in the new medical examiner's building?
Sure. So there's been some lengthy meetings with, of course, DPW, myself, and the medical examiner's office regarding site selection and the advantages and disadvantages to different sites. Looking at those, getting some idea of what they look like from I guess a 3D look, very general look on that, but just of what they look like on a horizon type of situation. And then some of the more programmatic type meetings have been happening directly with the medical examiner's office and the architects and the specialists that design medical examiners buildings about what would work best for them, the layout, how you can fit that into a certain site plan. So it's again, it's still at that high level. We haven't gotten down into the nuts and bolts of how you put it together or what's exactly going to be in there, but they're still doing the architects are still doing that discovery period with the medical examiner's office and getting ideas as to how they want to lay out and what would work best for them. I think it's been really, really productive. One of the architects that is subcontracted in the program is called Crime Lab Designs. So this is what they do, and you can tell that their expert opinion is well versed, as they've built many different types of medical examiner facilities and crime lab facilities. So right now it's going well. I think it is to get to what's going to be there. One of the things that we want to make sure of is that this facility is a welcoming facility, that it is respectable, that it is not something to be shunned, that not something that we need to hide in the back of our building, that it's a structure that is going to be welcoming to people who are in the worst days of their lives and may need to come there to identify someone or to have a meeting or whatever it may be. But we're taking that. It's a very important part to us and to obviously the county exec's office to make sure that it is a welcoming facility. And so we're taking that into account. So what's going to be there? Well, obviously, the medical examiners, mortuary facilities and where they do their work is going to be there, but also a place where someone can be counseled and consoled, where someone can be met with, where there can be a proper viewing if a viewing is needed, that is not standing in the middle of the autopsy room, but standing in an area that is comfortable from behind a glass window or something like that. Things that we definitely don't have right now. So that's a high level answer for you right there as far as what we're doing and kind of the progress we're going on. We have another meeting tomorrow, and I'm very excited about each meeting we go to. We take another step forward, and it's good because lots of discussions are coming out, and lots of questions are being asked, and problems are being solved before something gets built. So it's good. You're muted, sir.
And I'm sure plenty of storage for tissue samples and storage.
Well, operationally, that's a big part of this, right? So, again, it's so important that the medical examiner themselves, the ME, the chief ME, and the deputy are part of these discussions, and they're there at every meeting, and so they're giving us a real world look as to, hey, here's how many bodies we need to have capability of storage for, in a respectable way, and so all those things are being accounted for.
Okay, great. Thank you, Chairman.
Okay, Legislator Lujan.
Thank you, Mr. Chairman. Just very briefly, I a couple of months back, I had made a call actually to speak to someone because there was a family that was really obviously in distraught. They had lost their child. The circumstances were unfortunately very violent, and I'm really happy to hear about the changes that are going to happen. I think that these are really positive changes, and I think that you said it perfectly. This is the worst time in someone's life, in a family's life, and to be making the kind of changes that is really trauma informed and welcoming is precisely the kind of environment that we want to create for these families. And so I applaud the work of the health department on this, and I look forward to seeing what will come forward of it. Thank you.
Leader Amo, you still have your hand up, or is that before?
Before, I'm sorry, Mr. Chairman.
All right, no problem. Legislator Cheney.
Thank you, Chairman. Just a follow-up to Legislator Tui's question. The architect has requested to be on the agenda for the Physical Services Committee on Monday. That still needs to be confirmed, but my expectation is they will be there to talk to the Physical Services Committee about the process of site selection, primarily. I'm sure they'll be able to answer other questions as well, but take a look at your agenda when it comes out for Physical Services, as I expect that there will be an item on there for the discussion about site selection. Thank you.
Okay, thank you. Any other questions? Hearing none, all in favor?
Aye.
Aye.
Aye. Opposed? Carried. Item 2F is the monthly update. Commissioner Gelman.
Thank you, Mr. Chairman. The department has started to demobilize some of its large-scale COVID-19 response efforts as case numbers have consistently decreased over the last few months. Two primary goals of the department COVID response continue to be COVID case investigation, and that includes reviewing positive test results and preparing the information for contact tracing, developing and implementing quarantine isolation orders, and the secondary being vaccination implementation, tracking vaccine distribution throughout the county, helping residents determine where they can get vaccinated, and implementing department initially pods, and now we're transitioning over to the clinical and homebound model. The department call center is being phased out as the number of calls have declined. On June 18th, the call center will be shut down and all calls will go back directly to the department main number at 360-6600. All questions regarding COVID will go to the appropriate division in the department for follow-up. The county website COVID page continues to have information for the public regarding their state and federal guidance documents and updates. We also have a free app that continues to be available and has regular updates along with our Facebook page for the Orange County Department of Health, and that's typically regularly updated. We are continuing to recommend that residents go to vaccines.gov because by entering their zip code, they can look up the closest vaccination location with available vaccine types. As far as our clinic and homebound, the Orange County Department of Health is now scheduling regular COVID vaccination clinics at our health department regular clinic locations in Newburgh and Middletown. Residents can call 291-2330 to make an appointment at our health department clinics. And the county also continues to have available registration for residents who are homebound. We're continuing our homebound vaccination program, and any resident that is homebound can register at www.orangecountygov.com homebound vaccination. The nursing department has started vaccinating on May 25th. So all individuals that continue to register there have been contacted, and majority of them have been vaccinated already. We began offering the Johnson & Johnson vaccine for clients visiting our STD clinics. In June, essentially on June 15th, we will hold our first COVID-19 vaccine clinic at our regular scheduled location. Prior to May 25th, I have been predominantly vaccinating residents in their homebound addresses, and essentially that entails pretty much going door to door. I have been all across the county at restaurants, different locations, senior housing, congregate settings, low-income housing, and just regular households in Florida, Warwick, Newburgh, off the top of my head, Middletown, Wallkill, Pine Bush, essentially all across the county, vaccinating residents as well. The Office for the Aging has been gracious enough to take calls and register people who do not have access to a computer or the internet, and that number is 845-615-3700, and that is for homebound residents that do not have access to a computer or the internet. The Office for the Aging has been registering them as well. The county is no longer operating the mass vaccination pod site located at 23 Hatfield Lane. This location proved to be excellent in getting thousands, over 70,000 doses to county residents. As a matter of fact, our Orange County Health Department, our county, has administered more vaccine than any other local health department, as well as more vaccine than any other healthcare provider type in Orange County. So we are very proud of that fact, and we could not have done that without, of course, our Orange County Department of Health staff, but also tremendous amount of volunteers, Medical Reserve Corps, emergency services, and a lot of other county departments. We are continuing to coordinate as we essentially transition from the mass vaccination point of dispensing. We are continuing our outreach And our goal is to vaccinate as many residents as possible. And as the attendance at our larger pods decreased, we considered community locations that improve vaccine access for all of our residents in order to maximize outreach and improve vaccine equity. Since the start of county vaccination efforts, we've been very creative with vaccine outreach, ensuring optimal access with mobile clinic outreach, collaboration with community organizations, as well as regularly frequented places that have been ideal in the past for testing, as well as reaching populations who couldn't easily travel to a vaccination location previously. And in partnership with medical providers, our federally qualified health centers, volunteers, we have been able to convert mobile units that we originally deployed to the food pantries, low-income senior housing, congregate living environments, homeless shelters, faith-based institutions. Originally, they were utilized for testing purposes early on in the pandemic, and currently are being utilized as our mobile vaccination units. We are continuing, as I mentioned, to vaccinate homebound residents in collaboration with our visiting nursing services and other in-home providers. So we're not the only ones vaccinating homebound residents. And we have sent out alerts to all of the homebound resident lists that are available through our other departments, such as Office for the Aging, DSS, Mental Health, so on and so forth. And emergency services have also sent out through municipalities and their available lists of homebound residents, and also emergency lists that are available through power companies, just essentially the notification that this homebound program is available for vaccination. We have gone out in the field, as I've mentioned. We were vaccinating in bars, restaurants, recreational facilities, congregate housing, senior low-income residencies, places of work, places of worship. The Orange County, New York Department of Health coordinated a walk-in COVID-19 vaccination clinic at the Good Shepherd Episcopal Church in Newburgh on Saturday. That was June 5th. And we have collaborated with the Executive's Office and Reverend Deacon Chris Colon on potentially a future vaccination there in the community in coordination with Cornerstone. We are partnering up with a number of facilities to ensure that the smaller points of dispensing sites continue to vaccinate. And of course, it is imperative for everyone to see their primary care doctor for their medical needs, including vaccination. But we will continue to serve the community and ensure that every resident that wants to be vaccinated in Orange County has access to that vaccine. In terms of where we are in general, as I've mentioned, I'm very glad to report that we are seeing a continued decrease in cases in Orange County. And where we are right now, and this is through the 14th, we have had a total of 47,519 cases of COVID-19, which is roughly about 12% of the total population of the county. I have to mention that of those, 5,357 cases have been in the population 0 to 17. So we are seeing transmission, or we are continuing actually to see transmission in the 18 and under population. So on the contrary to popular belief, there is quite, and there was and continued to be quite a bit of transmission in residents under 18 years of age. In that demographic, we have had 30 hospitalizations among that age group, with an additional 4 visits to the emergency department, which were not hospitalized. But that's essentially in that overall demographic. And about 73% were under the age of 10. Over the past month, we have seen approximately 17.6 to 25% of cases, of total cases in the 18 and under population. So I thought that was an important emphasis as we move forward throughout the pandemic. We have had 842 confirmed deaths to date. As far as current caseload, we are seeing 68 cases now versus 84 cases from the previous week in terms of new cases. And the median age has shifted. We're seeing the median age at around 40 years of age versus 30 from the previous week. Our 7-day rolling percent positivity rate from the New York State Department of Health as of June 13th is 0.6 compared to 0.7 from the week prior. So all metrics, we are seeing a very consistent decrease in cases overall. Now, as far as our 7-day cumulative average per 100,000 population as of June 14th, it was at 17.7 per 100,000, and it's also a decrease from the last report of 24.2 per 100,000. And the C-COVID tracker, as far as their 7-day average, uses a PCR to calculate the burden, and that lists our community transmission now at a moderate transmission rate versus the previous substantial rate, which is calculated at 19.5 per 100,000. There have been a number of questions as far as vaccines, and I will get into the vaccination data, but in terms of what we're seeing as far as vaccine breakthrough. So vaccine breakthrough in fully vaccinated individuals, and the vaccination currently, as it's been reported on the New York State website, for Orange County, we have had 156,379 residents that are fully vaccinated, meaning they completed their vaccine series, 1 dose for Johnson & Johnson and both doses of Pfizer and Moderna. So for those individuals, of course, being fully vaccinated 2 weeks out from their final dose of vaccination, the New York State Department of Health is reporting a total of 45 individuals of those that have been fully vaccinated that have been reinfected. Now, we are seeing some anecdotal cases, and the New York State Department of Health still has to catch up, so we're working with New York State Department of Health to obtain the updated numbers, but they are generally in that vicinity. So in terms of vaccine breakthrough data, we have seen 45 cases out of 156,379 fully vaccinated individuals that, when came in contact with COVID-19, have been infected. That, of course, is a very small percentage, so that's at 0.02% vaccine breakthrough. When compared to the rest of New York State, New York State reports an average of about 1% vaccine breakthrough in fully vaccinated individuals. And as far as clinical trials, those reported at about a 5%, depending, of course, on vaccine type, around a 5% vaccine breakthrough, again, in fully vaccinated individuals that were exposed to COVID-19 that have contracted the disease. Now, I am glad to report that of those individuals that have had that vaccine breakthrough, meaning they have contracted COVID-19 even after being fully vaccinated, none have been hospitalized, and no cases have been reported as far as hospitalizations or deaths. That's a tremendous number. It's very important to note we had hundreds of individuals that have had COVID-19 in the past that have been reinfected with COVID-19 subsequently months later. So it's another testament to the fact that it's imperative to obtain your vaccination and, more importantly, ensure that you're receiving both doses of vaccines. As far as vaccination in general, hospital workers, I'm extremely glad to report this, that hospital workers in Orange County are over 80% vaccination and higher than the Mid-Hudson and the statewide percentages. However, skilled nursing facilities and adult care facilities, again, unfortunately, remain under-vaccinated as far as what is necessary to stop that propagation of disease within the facility. So we are seeing infection continue. Skilled nursing facilities continue in Orange County to be at 58% vaccination. That's under the Mid-Hudson average of 66% and under the statewide average for skilled nursing facilities at 63%. And adult care facilities are also at 62% in Orange County which is below the 74% in Mid-Hudson for same facilities and below the 70% statewide vaccination for adult care workers. On a bright note, the skilled nursing facility resident rates are quite high as far as vaccination. So skilled nursing facility resident percentages of vaccination is at 89%, which is higher than the Mid-Hudson 87 and higher than the statewide 85%. As far as areas within the county, and this is according to the vaccine hub, which is Westchester Medical Center, zip codes within Orange County that remain under vaccinated per capita as far as their population: Monroe in Orange County, Otisville, Highland Falls, Cutabackville, Southfield, which I believe to be part of Tuxedo, Westtown, Port Jervis, Huguenot, and Sparrowbush. And this, again, this is as it is reported from the Westchester Medical Center vaccine hub, as far as 30 zip codes throughout our region, and that includes Sullivan, Rockland, Orange, and Westchester and Ulster counties. Within the same vein, the American Medical Association has indicated that 96% of practicing physicians have been fully vaccinated for COVID-19. So the nation's largest doctor group has stated that not only 96% of their practicing physicians have been vaccinated to date. Of the ones that have not yet been vaccinated, 45% reported that they plan on getting vaccinated, which is an astonishing, I think, statistic, because clearly for anyone that is still hesitant about vaccination, just ask yourself, what is it that you believe to know that the nation's practicing physicians don't at this point? In terms of other reports, and we are transitioning back to our regular mandated programs and our regular case burdens. We are continuing with all other programs in the health department. I am glad to report that congenital syphilis cases for this year are decreasing according to New York State. However, we still remain #1 for HIV concurrent with syphilis infections within the state, as well as syphilis infections, newly diagnosed syphilis infections in New York State. And we are #2 as reported by New York State as far as congenital syphilis cases, and that's as of last year. So there's still a lot of work that remains to be done in that area. And while we are still on the subject of vaccination, the Advisory Committee on Immunization Practices will be meeting on Friday, June 18th, to discuss COVID-19 vaccination. As I'm sure you've heard, there have been some reports in the news as far as vaccine safety, specifically mRNA vaccines, which includes Pfizer and Moderna vaccines. And they will be evaluating the recently reported incidences of myocarditis after administered mRNA vaccines. I will say that COVID-19 should absolutely scare individuals who are worried about myocarditis a whole lot more than the vaccine, because incidence of occurrence of myocarditis in individuals with COVID-19 among that age cohort are a lot higher than incidences of myocarditis post vaccine administration. Since April 2021, there have been these cases that have been reported. Essentially, as of June 10th, the CDC confirmed 226 cases of myocarditis after COVID-19 vaccine administration in people under 30 years of age, predominantly male, and 250 more reported cases are currently under investigation. But please keep in mind the relative context of that. This is out of millions of individuals that have been vaccinated with that vaccine. And when compared to incidences of occurrence of myocarditis after COVID-19 infection in the same age group, the American Academy of Pediatrics reports 1 to 3% of total amount of cases of COVID-19 in individuals under 18 years of age and younger. So when we are examining the 18 and younger category, the incidences of myocarditis in individuals with COVID-19 not only occur more frequently, but also are a lot more severe. So an analysis, this is an analysis of the data of the vaccine safety data link surveillance system, and they have found the rate of 16 cases per million in second doses in people ages 16 to 39. So clearly the risk of myocarditis or even pericarditis in individuals that have contracted COVID-19 in that age category versus obtaining vaccine, the statistics essentially speak for themselves. As far as what myocarditis is, it's the inflammation of the middle layer of the heart wall. And the severity of cases of myocarditis and pericarditis vary. Typically, it's very rare to see these incidences. That's why the CDC is convening this panel on safety to evaluate the safety of mRNA vaccination. But for the cases reported after mRNA COVID-19 vaccination, most who presented to medical care have responded very well to medication and rest. And almost all cases among that vaccinated young people, and they were ages 16 to 24, as I mentioned, predominantly male, the symptoms have quickly resolved. Much more severe presentation after COVID-19, and of course, a lot more questions remain to be answered regarding other possible contributing variables in that age cohort, underlying disease presentation. We have seen millions of doses being administered and only a few hundred cases reported to date. So it remains to be seen if there is that causation versus correlation factor with vaccine administration. In the same realm, and quite similarly in May, I have reported 28 cases of thrombotic events in the presence of thrombocytopenia, which were very unique. Those were reported predominantly in females, age 18 to 48, with administration of Johnson & Johnson vaccine. And again, the safety and efficacy is being examined, and the causation versus correlation is being examined. But again, when we are comparing that to the baseline of vascular complications in individuals who have had COVID-19 in the same age cohort, overall, we are seeing vascular complications with individuals that have contracted COVID-19, because that incidence of occurrence for vascular complications is 1 out of 6 people with COVID-19 who have had vascular complications. So hopefully that provides some relevant context in reporting and just examining this data for yourself. As far as the State Department of Health reporting multi-system inflammatory syndrome in children, the state has been investigating about 500 cases, reported cases, and 2 deaths in New York children, predominantly school-age, experiencing symptoms which were originally reported as being similar to Kawasaki disease and toxic shock-like syndrome, possibly due to COVID-19. And of the children displaying these symptoms, 98% tested positive for COVID-19 by diagnostic testing. So that's as far as some news that have been linked to vaccinations that may potentially contribute to more vaccine hesitancy. Now, another slight issue that I would like to address, many have voiced opposition to mRNA vaccines due to potential of incorporation of the mRNA construct into our cell's DNA. And not to go into cell biology, but the overarching reason to really not buy into that type of thinking is because just simple and fundamentally, mRNA does most of its work in the cytoplasm and cannot enter the nucleus where our DNA resides. So just plain simple cell biology would not allow for that to happen. And one just very basic factor, the actual virus can change the DNA. And as a matter of fact, there are line 1 endonucleases that can do the same as the reverse transcriptase enzyme, which converts RNA to DNA. And generally speaking, 17% of our genome is made up of old viral segments introduced over time into our genomes. So 70% of our genomes is modified by prior viral infection. So again, just to address some of the misinformation that abounds There are specific reasons that it's just not really something that we're even contemplating. As I was preparing for the meeting, the governor announced today that COVID-19 restrictions are being lifted because 70% of New Yorkers aged 18 or older have received their first dose of vaccine. So this does not include individuals that are fully vaccinated yet. Hopefully they will all be vaccinated. And clearly this includes adults 18 years and older. And unvaccinated individuals continue to be responsible, and this is for New York State Department of Health, for wearing masks in accordance with federal CDC guidelines, consistent with the state's implementation of the recent CDC guidance. The state health guidelines continue to be in effect for large-scale indoor event venues, pre-K, grade 12 schools, public transit, homeless shelters, correctional facilities, nursing homes, and healthcare settings, again, as per the CDC guidelines and as per the state of New York. So overall, we are seeing quite promising indicators. Pfizer has applied in May for FDA approval for the vaccines that they have available. Pfizer also has issued a number of promising studies as far as the 2 to 5 year old range and the 5 to 11 year old cohorts, and they are hoping that by September that vaccine will be available and will have at least emergency use authorization, if not approval, by the fall. And for the fall, in terms of prognosis, clearly the rate of infection will depend on the total number of vaccinated individuals, and we're discussing individuals that are fully vaccinated, because quite often we're hearing reports of individuals that are 18 years of age and older, as far as statistics on vaccination, but the propagation of disease happens in all individuals, not just those 18 and older. So it will be very important to see where we are with pediatric vaccination by the fall. So the number of vaccinated individuals of all ages, as well as the circulating variants of the virus at the time, that will really be the basis for gauging where we will be in the fall as far as new cases and as far as potential for necessity of boosters, because the less of the overall public that is vaccinated, that's ample opportunity for the virus to propagate, mutate, and of course these variants may necessitate potential boosters. The final point, and I promise I see kind of that I'm losing the attention span, I would like to address the previous question of legislator Amo as far as vaccines among the immunocompromised population. And when we are discussing the potential for boosters, clearly it's very important to know where we are with overall rates of transmission, where we are with circulating variants and these mutated strains, and where we are in terms of immunocompromised and more susceptible populations, which are typically considered populations 50 years of age and older when we're discussing boosters for vaccines. So in the United States, 3 to 5% of the population is considered to be immunocompromised, but it's very important to note that some immunocompromised groups were included in clinical trials already. So out of the thousands of individuals that participated in clinical trials, that included participants with HIV, AIDS, and other immune specific disorders. So when we are discussing safety, mRNA vaccine is very safe among the immunocompromised population, and of course that includes solid organ transplant recipients and other immunocompromised positions. However, the worst news as far as effectiveness of vaccine in the immunocompromised population. There's a very broad range of efficacy that's reported after vaccine trials that have included these different cohorts, and that range is, it's a very broad range. It ranges anywhere from 17 to 80% efficacy as compared to other cohorts. And the reason for that, it's really dependent on the type of condition, whether we're discussing an HIV patient or an organ transplant patient, a patient on dialysis, cancer, so on and so forth. And when we're discussing immunocompromised position, are we talking about immunosuppression or potentially immunosuppressive medications such as steroids? So, in short as this can be, it really will depend on the type of underlying condition and on the corresponding treatment regimen. So again, even with this cohort, it's important to speak with your doctor, get vaccinated, but this demographic may need to continue with some precautionary measures and may potentially need boosters down the road, as I've mentioned, based on the circulating viral strains and the percentage of the total population that's vaccinated. I think that is all for the time being, and I will be glad to answer any questions.
Leader Amo, did that satisfy your question from last month? Legislator Tortel.
Thank you, Mr. Chairman. Thank you, Dr. Gelman. Just could you repeat, you had, were quoting statistics from something from Westchester Medical Center, and you mentioned the village of Highland Falls. Could you repeat? Yes. I couldn't quite hear everything.
Yes, absolutely. So these were the top 30 zip codes with lowest percent administration of doses of vaccine, as reported by Westchester Medical Center, which is our vaccine hub, our regional vaccine hub. And it lists, of course, 30 zip codes with the lowest percent of administration of vaccine doses. And of those, they were Monroe, Otisville, Highland Falls, Cutterbacksville, Southfield, Westtown, Port Jervis, Huguenot, and Sparrowbush. And this is in Orange County. There were others of the 30, but those were in Sullivan, Rockland, Westchester, Ulster, and other counties.
And then another kind of, it's a floating question that people keep asking. If a person is fully vaccinated, obviously they can still contract a variant of COVID. Can they also be a carrier where they're infecting somebody else?
Yes, they can potentially transmit as well, but as I've mentioned, that breakthrough percentage, as in clinical studies, we saw 5% breakthrough as far as individuals that are fully vaccinated 2 weeks out from their final dose of vaccination, contracting and or transmitting COVID-19. That percentage of breakthrough, is, as reported by New York State, has been 1%. And for Orange County, currently, it's about 0.02. I suspect it's a little higher than that. We just haven't caught up on it, but it's still under 1%. So that's where we are.
Okay, so if, sorry, Lawrence, I'm going to throw Valley View under the bus just to use it as an example. If somebody is caring for a vulnerable individual who, for health issues, they cannot get vaccinated, do say, like, you know, a staff member at Valley View is caring for a Valley View staff resident who can't get vaccinated, are we still going to keep the mask protocol in place, and is it recommended for that person to wear a mask, even though they may be vaccinated, the other person can't?
So thankfully for healthcare settings, and as I mentioned, even with this current pretty much lifting of a lot of restrictions with the 70% that New York State reported for adults 18 and over having at least one vaccine, unvaccinated individuals have to continue with the masking protocols, but also those settings that I've mentioned were excluded from lifting of this masking mandate, and that's large-scale indoor events, pre-K through grade through 12 schools, public transit, homeless shelters, correctional facilities, nursing homes, and healthcare settings for the CDC guidelines. So nursing homes are explicitly included in that. So if someone is unvaccinated caring for an individual who's vaccinated, and typically in healthcare settings, you tend to see some of the protocols regardless. Healthcare providers typically wear masks in certain settings and gloves and so on and so forth, just universal precaution. But nursing homes and healthcare settings were specifically included as continuing to mask.
Okay, so if a visiting nurse, a physical therapist, so on and so forth, is coming to a home, that physical therapist or nurse is vaccinated, but they're taking care of a patient who can't be, they will still need to follow the protocols, correct?
Yes.
Okay. Because that's what people were getting. I had some people who have home health care, and they're like, making them wear the mask. I said, I'm pretty sure they still have to wear the mask, even if they've been vaccinated. I just wanted to double check with that to make sure I was correct.
Yes.
Thank you. Thank you, Mr. Chairman.
Thank you. Any other questions? I don't see any. Thank you, Commissioner.
Thank you.
Item number 3, Commissioner Ledoux, monthly financials.
Sorry, I just need to. Yeah, Donnie, get started.
Hi, good afternoon, everyone. The results we're looking at today are as of May 2021. I'm just going to hit some of the highlights. IGT funding has not changed since the last publication, 1.5 million. Other revenues coming in at 12 million. Personal services, we've spent 8.3 million so far. Equipment, just under 15,000. On the contractual side, we have 4.3 million earmarked for expenditure, and we've actually expensed 3.2 million. Employee benefits coming in at 7,350,000. Overtime expense for the 10 pay periods in May 2021 totals 767,000. If you turn to the next page, you'll see our census. So in May, our census totaled 76.47%. The average performance for the first 5 months of the year is 72.83. And the last page, you can see the historical census.
June census is 79.48% as of today. I sent out a quick monthly update. I just mentioned the June census. We currently have 3 COVID positive residents. 2 are in-house. 1 is at the hospital. We have 2 staff members that are currently out due to COVID. 93% of our residents have been vaccinated. 59% of our staff have been vaccinated. We continue to regularly offer the vaccine to both residents and staff. The COVID staff testing requirement just changed last week. Staff that have the COVID vaccine no longer need to test regularly, except during a new outbreak of the COVID positive resident or staff, which is going on now. And staff that aren't vaccinated still must get tested twice a week. Our CHA currently has 12 patients in it, and the New York State recently passed new nursing home legislation that establishes personal caregiving and compassionate care giving visitors. This allows residents to identify a minimum of 2 personal caregiving visitors at one time during public health emergencies. And we have been allowing compassionate care visitors to come inside the facility as family members. And that's all I have to report.
Okay. Any questions before we get into the financial report by O'Connor Davies? Any questions for Commissioner Ledoux? I don't see any, so thank you. Now we'll go into the last item on the agenda, which is Valley View's 2020 financial report by O'Connor Davies.
Great. Thank you. Thank you.
You're welcome.
This is Chris McCarthy. I'm one of the partners who handles the audit along with Michelle O'Reilly, who is also on. In addition, we have Jim Stetz, who is the manager, and Andrew Martini, who is a senior on the engagement. From the standpoint of divvying out responsibilities from as far as partners, I handle primarily the reimbursement related issues, Medicaid, Medicare, due to and due from third-party payers, and Michelle O'Reilly handles really the basic blocking and tackling, the accounting, the gap related disclosures, basic financial statement audit, and accounting. So what we'll do is we'll kind of walk through, both Michelle and I, kind of a tag team approach as we walk through. Everyone should have received, and I think, Andrew, are you going to bring up the PowerPoint first? We'll
Yeah,
walk-
can everyone see it? I'm sharing it right now.
Yes.
Yes.
We'll walk through first the PowerPoint itself. We also have financial statements as well as a supplemental schedule that I put together that maybe will help with the presentation. And I believe everyone did receive the actual PowerPoint. I assure you, we're not going to cover every single slide during our presentation this evening. But as I said, Michelle and I will kind of bounce back and forth. Michelle, you want to kind of kick off with the engagement status?
Sure. Hi, everybody. So we can hop to page 3 just to talk about the engagement status. So we have completed our audit. We had no unforeseen circumstances that we had to address, so we were able to complete it in accordance with our audit plan. We have issued an unmodified opinion on the financial statements, so that's the auditor's clean opinion, the highest level of assurance that you can receive. And you all have copies of the issued financial statements with you. The cost reports are in process. Chris and his cost report team have been working on those with management. And then in addition, because of the CARES Act funding that you received that we'll speak more about further along in the presentation, you will be required to have a separate additional audit under the Uniform Grant Guidance for receiving provider relief funds greater than $750,000. That due date has just been extended, so that is due on or before March 31st, 2022. We can hop on to the next page. So the next couple of slides just cover the auditor's responsibilities and management's responsibilities. I'm not going to go through every one since you'll have these as a takeaway, but just to highlight on some major points. As auditors, we take a risk-based approach to the audit. So that means we look at material areas or items that we think have risk related to them. We do not do 100% testing. We also look at different areas each year as an area of focus. So we're not focusing on the same areas each year. And we do follow, our auditing standards that we're supposed to do. We can hop along to page 6 on the slides. This just talks about some of management's responsibilities. Really that's to appropriately account for everything, fairly present your numbers, keep good internal controls, comply with laws, regulations, and so forth. Those charged with governance, which is this committee here today, is responsible for overseeing the financial reporting process and communicating with us. So, we're covering that today by giving this presentation to you. So certainly if there's any questions along the way, because we can't really see everybody, please feel free to interrupt or raise your hand and we'll try to address your questions as best as we can. We can move on to slide 7. This talks about a little bit more about the audit scope and approach. Listed here for you are some of the significant audit areas that we covered. We're going to get into most of these on the slides as we progress through them. So again, these are here for your reference. And I think that we can move on to page 9. So, this year is, second year with COVID. For your 2019 audit, we were actually able to complete your field work before the shutdown occurred and we're on site in order to perform our audit. So for 2020, we really had to do everything predominantly remotely because of COVID-19. So that changed the way we did things a little bit. So we used a portal to share work papers that kept information secure and in compliance with HIPAA laws. And then we used tools like Teams, like we are today, Zoom, and just phone calls to review different analysis, ask questions, and to keep current with management. We had frequent meetings with management of the facility throughout the course of the audit. You'll also note when you take a look at the financial statements, if we move on to page 10, please, that you're going to see note disclosures in the financial statements regarding COVID-19. As everybody's been aware, everybody's aware, this has been so pervasive worldwide and has had significant impact on operations and cash flows and financial conditions, not just for you or other nursing homes, but for largely all industries. There's discussions on it in the financial statements. Every 2020 financial statement for every industry has COVID-19 disclosures. And then again, because you received about $2.5 million in stimulus funds from the CARES Act, these provider relief funds, that requires a separate compliance audit called a single audit under the Uniform Grant Guidance, because more than $750,000 of those funds were received. Any questions so far before we move on?
And just to piggyback on what Michelle was saying regarding the provider relief funds, I'm sure everyone's been reading about this and well aware. It was about $178 billion in funding was made available. Most of it has been distributed. There's probably, I want to say, there's about 24 billion still not distributed of the 178 billion. Of the 178 minus the 24 billion that was distributed, believe it or not, only about 14 billion went to skilled nursing facilities and assisted living facilities throughout the country. A lot of it went to large hospital systems and other types of providers. So only about 8 to 9% right now of the $178 billion was actually distributed to skilled nursing facilities and assisted living facilities. Of that 24 billion, there's hope that as much as maybe 10 billion of that of the 24 that has not been distributed will go out to skilled nursing facilities and assisted living facilities. There's an extensive amount of lobbying going on. I think the belief really is that that's where a lot of the funding is required. Just as I said, about the 178 billion, there are about 411,000 entities, physician offices right through the largest healthcare systems that received provider relief funds in 2020. It ranged from $1. 49 entities actually received $1. I don't know what you could do with $1, but they received $1. The largest distribution was for $1.2 billion, and I went to, anyone want to guess? New York City Health and Hospitals Corporation, $1.2 billion. Then you have New York Presbyterian Hospital, $631 million, Montefiore, $467 million, before you start getting into places like Dignity Health, which is out in Vegas, $431 million. So again, over 400,000 entities received the funding. But the largest was New York City Health and Hospitals Corporation, the 1.2 billion. If you wanted to advance, Andrew, to slide 11, we'll get into the nitty-gritty of some of the items with the audit itself. This schedule here just shows it's a comparison first between 20 and 19, looking at your accounts receivable and your net patient service revenue. I know you've been, from the audit, we look at all the minutes. Obviously, Lawrence and his staff were reporting to you the census changes and the census decreases. And that wasn't unique to New York. I mean, the entire country was experiencing some pretty significant drop-off in census. Lawrence, I know I'd mentioned you about 78, almost 79%. The statewide average is just hitting in June, just hitting about 80%. New York State tends to have the highest occupancy of all the 50 states when it comes to skilled nursing facilities. As expected, though, both accounts receivable and revenue went down because of the census drops. I think one of the key areas to look at when we look at accounts receivable, from an audit standpoint, it's one of the more difficult areas to audit, because in a typical non-healthcare environment, accounts receivable, the easiest way to gain evidence about unpaid bills is to send confirmations out to those individuals that have not paid amounts. But when it comes to healthcare entities, Medicaid, Medicare, and other insurance companies, whether it's those insurance companies that handle Medicare Advantage plans or those insurance companies that are handling Medicaid long-term care contracts, they generally do not respond to confirmations. So the audit really becomes one of looking at hindsight reviews as well as looking at subsequent receipts. So we spend quite a bit of time looking at accounts receivable, doing alternative procedures. One of the things we look at is we look at the average number of days it takes to collect. In New York State, generally facilities run between 50 to 60 days in that range when we're doing the actual calculations. In 2020, you're down to about 51 days, which is an improvement. And we see that steady improvement over time. And that's for a variety of reasons, but one certainly is working those accounts. It's easy to send out a bill. The most difficult part of that job is going after and chasing down, whether it's, Medicaid, Medicare, third-party payer, dealing with the family member, trying to explain why the Social Security check has to be remitted to the nursing home. There's a lot of work that's involved there. But it's great to see that at least your days in accounts receivable are certainly within range. If you jump to slide 12, as you see the real impact, and we'll look at that when we look at the financial statements. We see the net patient service revenue. It's census, and you can see that your census for 2020 ran about 84%. About 84% of your beds were occupied, whereas in 2019 you were at 93.5%. That's slightly better than the statewide average of 93.5%. And you can see the actual impact of the days. You have to just keep in mind the typical skilled nursing facility, most costs are fixed costs when you're outside of the salaries of the individuals. So whether you're 93% occupied or 84% occupied, utilities tend to be about the same. And a lot of other fixed costs, interest on mortgages and things like that, depreciation on the building and equipment, that stays. Some interesting things, and we're going to look at some of the rates, but just so you understand, Medicaid, and we're going to look at that in a little while. Medicaid runs about 80 to 83% of your patients are Medicaid patients. That pays the lowest rate. Medicaid pays the lowest rate, not only at Valley View, but basically throughout the state of New York. The highest rate on average is paid by Medicare. You run about 13 to 15% of your patients are Medicare. The tough thing with COVID is COVID had a real negative impact on getting those Medicare patients. The Medicare patients are those shorter stay patients, generally coming for therapy. So you may have someone who maybe decided to, the hip replacement, finally said, let's have this hip replaced. Let's get into the nursing home. Let me get my skilled nursing, predominantly rehab. That patient tends to shy away right now from skilled nursing facilities. So that hurts. But we'll look at it in a little while, a little deeper. So again, your occupancy dropped like the rest of the state as well as the rest of the country, but you are bouncing back, and it's great to see. Slide 13 is just, if you're an audit techie, it's some of the stuff there we actually do. It's just describing some of the actual work that we perform. Slide 14, due to and due from third-party payers. I guess this is somewhat unique to healthcare, and I guess the easiest way is to say, why are there amounts due to or due from third-party payers? And I guess the simple answer is, if generally Medicaid would pay the right rate and pay it on time, you wouldn't have due to, due from third-party payers. It's predominantly Medicaid. And there are some timing differences. And as they try to process and keep the rates moving, the rates change at least twice a year. There are some real time lags, and that time lag is what generates these overpayments or underpayments. So during the year under audit, the cash assessment reconciliation, you're receiving an extra $96,000. That's coming in anticipate probably late 21, 22. The quality pool, there's always at least a year behind. So New York State issued in 2021, they issued the 2019 quality pool. You received an award because you fell into the second of the 5 quintiles. The first and second receive money. The third, the fourth and fifth pay money, and a third is almost break even. So by coming the second quintile, Valley View was designated as a facility that was awarded because of the quality. So you met the quality indicators that they were looking for. So that's about $159,000 of additional reimbursement you received because of the quality pool ranking. The third of these 1% supplemental payments was received. That's about $290,000. That came in 2021. It was accrued into 2020. Probably the biggest negative was your case mix dropped. And your case mix is, again, that's calculated twice a year for all your Medicaid patients. When your case mix goes up, your rate goes up. When your case mix goes down, your rate goes down. And here's where you start to see the problem when a state is slow in processing rate increases or decreases. You were being overpaid. You may recall part of it we spoke about last year, this body mass index. You were being over reimbursed for that. But it takes them so long to get that back out of your rate that you were constantly being overpaid for that plus the case mix. So your organization recorded that liability at year end. It was about a $2 million reduction in revenue. Again, it was not an unknown. The facility was on top of it as far as these items. So that was set up as a liability. So amounts due to and due from third party pays where we spend quite a bit of time. It's fairly stated. If you want to jump to slide 16. Any questions so far, by the way? Just some things before we jump into the actual financial statements. I say here, continuing third-party reimbursement opportunities and challenges. I mentioned before about Medicare and Medicaid rates. You could see right here, the average rate, there's a multitude of rates paid to Valley View and the other skilled nursing facilities. And there's about 600 skilled nursing facilities in the state of New York, 13,000 nationwide. Your average Medicare, you average about $673 a day for reimbursement from Medicare, traditional Medicare, for each patient that is a Medicare Part A covered patient in your facility. I highlighted that in black. If you look down, I have in bold the Medicaid rate. Medicaid rate for Valley View is about $267 a day. Just think about this. 2 patients, a Medicare patient, you get paid $400 more per day if it's a Medicare patient than you do for a Medicaid patient. And it's not like Medicare is overpaying you. It's just that Medicaid, not only in New York State, but unfortunately throughout the country, is woefully underpaying skilled nursing facilities. It's just part of the state budget, no matter what state you look at. New York, I think, we're probably okay. But when you typically looking at the cost of care for a patient and what Medicaid pays for that patient, typically you'll see that for every dollar of expense, you're only getting paid about 80 cents. What we're starting to see is that's getting even worse. Now it's starting to slip down to 70 cents. So you're in a sense, you, like all other skilled nursing facilities, are in a sense losing by caring for Medicaid patients. And how do you make it up? You make it up by having your Medicare patient population, your private pay population. So it's a real challenge, and it's not just a challenge at Valley View or New York State. It's a challenge nationwide, juggling this. A couple real positives that Medicare did, and I want to stress this because when I get to Medicaid, any questions? I'm sorry. A couple other positives with Medicare. Once COVID hit, Medicare, working also, CMS, you have the Department of Health and Human Services, they're pushing out the provider relief funds. Medicare looked and said, okay, there's a couple things we have to do. Number one, if the facility needs, we'll give them an advance on their funds. It's not a loan. It's not a free donation. If they take the advance, we're going to take it back from them. They also said there's what is called a sequestration. Each time you're getting paid by Medicare, Part A, Part B, and it's not just you, it's physicians' offices, all payers, there's a sequestration amount. They take back 2% of your net check, and it's part of balancing the federal budget. They turned that off. So they said, wait, COVID is your nursing homes, other healthcare providers, you're in dire straits right now. The last thing I'm going to do is continue to grab an extra 2% of your check. So they turned that off. That helped Valley View. Was probably, I even have here, it's about $140,000 at positive to Valley View by doing that. But now I just want to jump down to Medicaid, because there's where you're going to see where the negatives. Medicaid, on April of 2020, they implemented 2 cuts in the industry. COVID hits in March. A month later, they're cutting rates. They cut everyone's capital component by 5%. So that hit Valley View for about $60,000. And you want to say, well, what's the annual impact? You know, when you cut the capital rate is the depreciation, the interest on the mortgage, the property insurance. That's unique for all facilities. There's a piece of the rate that's pricing, and there's a piece of the rate that's unique to each facility based on its cost. The annualized impact of that by doing that was a savings to New York State of about $24 million. So here, COVID hits, nursing homes are trying to respond, and the state adopts one of two changes. The first one is this cut, which they pushed through. As I said, it's about a $24 million annualized impact across the industry in New York State, and they're going to, and that's been continued. The most recent budget that was passed, it's in there as well. The other thing they did is, you remember I mentioned Medicare has a 2% sequestration, and they turned that off. Well, Medicaid liked that, and they said, we've never had that, so let's adopt that. So they adopted a 1.5% sequestration. So every check that you're receiving, Valley View receives from Medicaid, Medicaid grabs 1.5% of it and puts it back into their pool of money. There are some other proposed changes that Medicaid is proposing. Probably one of the strangest ones, and when I say strange, they want to mandate minimum staffing. And I think if you speak to any Lawrence or any other administrator working in skilled nursing facilities or in hospitals, they'll say the same thing. Our biggest problem is finding nurses, finding LPNs, RNs, CNAs. That is our biggest problem. So for the state in this particular case to come over and say, we're going to mandate a minimum 3.3 hours of nursing care per day, you say, that's wonderful. Where am I going to find these nurses, these RNs, LPNs, and CNAs to perform this work? So it's a real dilemma right now that the facilities will be facing. This kicks in 2022. And by the way, this tends to be something that will negatively impact for-profit nursing homes. And I think that's probably part of the reason for this. Not-for-profits and government facilities such as Valley View, you tend to have sufficient staffing. It's the for-profits that tend to have a lighter staffing, and that's who they're going after. The scary thing, though, is they're doing this. They're looking at 7 days a week, 365 days a year. So that minimum staffing, you may be doing real well 5 days a week, but on the weekends it's more difficult. You know, what about holidays? So there's concerns about when you don't meet the minimum staffing, whether it's you, Valley View, or any other skilled nursing facility in the state of New York. If you don't meet the minimum staffing and there's some sort of penalty, the state is saying they'll take that cash, they'll set it into a pool, and will become part of this quality pool. So there are plenty of challenges that Valley View faces, as do the other 600 plus skilled nursing facilities in the state of New York. I do want to say before we look at some of the financial statement highlights, which is the next screen, Andrew. Personally, I want to thank Lawrence, Donna, Tammy, and the staff at the facility. You know, while they're juggling and trying to figure out census, staffing, COVID, and anything related to that, you know, they have us, the CPAs, and I think I said this last year, we know what that stands for, constant pain in the ass. You know, here we are bugging them, hitting them with questions on, and so we have to apologize, but at the same time, we really do appreciate, because as frustrating as it must have been, you know, these team meetings and the Zoom calls and the telephone calls, and what do you have? You have us while you're trying to juggle everything else. So we really do appreciate, you know, you and your staff. So I wanted, you know, the legislators to realize, you know, that we really do. We were able to conclude this audit efficiently because they put in a lot of time. So we appreciate that. But we know CPA is also certified public accountants. So Michelle, do you want to just, you know, and by the way, the next two slides, and I have something that maybe will make this a little easier to understand. You know, when we look at a financial statement of a commercial entity, or whether it's a for-profit or not-for-profit nursing home, it's pretty straightforward. We know what we're going to see. We know when we look at the income statements, You'll have operating revenue and operating expenses. And what you hope for is that the operating revenue, what you're charging or what you're being paid by Medicaid and Medicare, you want that to be more than the expense that, or the cost incurred to care for patients. It's like any other business. So whether you're for-profit or not-for-profit, it's got to be the mentality generally of, well, I'd love my revenue to be greater than my expense. Is that the case in reality? It truly is not. I can assure you, forgetting what the for-profits may do for a typical not-for-profit, even before we look at public entities, not-for-profits, very few of them actually make money. Some of them fortunately have portfolios, they have endowment funds, contributions, and that's what helps them get along. Government entities, you have the IGT, which is wonderful, but at the same time, not 50% because it was changed, but at least 45% of it you have to kick in as the county. So when you look at financial statements of a publicly operated skilled nursing facility, it's always a lot of wacky things. When I say wacky, it's not what you typically would find in a skilled nursing facility that's either for-profit or not-for-profit. And it's driven primarily by GASB, the Government Accounting Standards Board. So what we wanted to do is just kind of show you a good snapshot, and then we'll talk a little about comparing a public entity such as Valley View to the typical not-for-profit and where we see the differences. So any questions, by the way, before we start to do that? Okay. Great. So Michelle, you just want to kind of take a broad overview right now of just the statement of financial position here?
Sure. Thanks, Chris. So as Chris mentioned, this is just some financial statement highlights. A draft of the actual financial statement was distributed, and we all know that you're familiar with the overall results from frequent updates that management gives you. But here, you can see, the current assets, they decreased about $3.3 million. Your non-current assets increased, but it's really with relation to the GASB entries where you're going to see the major changes here in the statements of net position. Deferred outflows of resources, that's related to OPEB and pension, that had a $30,000 increase. Corresponding, 30 million. Thank you, Chris. Increase correspondingly, you're going to see down in the liabilities where your current liabilities, increased a little bit, but those non-current liabilities where the OPEB liability is sitting and your pension liability is sitting, that increased about $50 million related deferred inflows and outflows. So, that brings your net position down to a deficit of about $140 million. You do have about $8 million sitting in investments in your capital assets. So, that's really just a broad overview. We know Chris touched on that your receivables are down for this year. Your IGT is up for this year.
If you just turn to the next slide, and this is the one, we have a couple different ways of presenting it, just, so as a reader of financial statements, because this is what I do when I'm trying to figure out, okay, what's going on. And I always realize, wait, I'm looking at a municipal operated skilled nursing facility. So I know there are differences very specific as it relates to recording GASB adjustments. This was just kind of a quick snapshot. Operating revenues, operating expenses, you could see that you change operating revenues down about $5.6 million. And that's driven primarily, we know, by census being down because of COVID. That's really the driving force. Operating expenses, you look and say, it's up $11 million. Look at that swing. So that $11 million swing, if you go down below, and again, I have a separate thing I'm going to have Andrew put up on the screen. Hopefully everyone can see it. It was another way of attempting to look at this. When you look down below, you'll see on the change column, you'll see that the pension adjustment is up about $3 million over the previous year, and the OPEB adjustment for that's the other post-employment benefits, that's the life, health insurance for life, those benefits, it's up almost $8 million. So you start to see that and you say, well, my expenses went up $11 million, and you can almost identify to these two. In fact, when we take a look at the income statement of the financial statements themselves, you'll see that for the most part, your expenses are flat year over year, except when we look at employee benefits. So I don't know if everyone can see this. Any way of making that a little larger? Andrew? Yeah, what I want you to do, Andrew, I wanted you to bring up to the screen that supplemental schedule I did. Yes, so if you can make that a little large, and just please enlarge that. So what I did here was I looked at the employee benefits for Valley View, and we do this with all our publicly operated skilled nursing facilities. I looked at the 2019 employee benefits, and that's when I say employee benefits, we're talking about payroll taxes, FICA, Social Security, unemployment, workers' comp, health insurance, all of it, plus the adjustments for GASB, the pension. You run about $23 million of employee benefits 2019. Big jump employee benefits, that's that 11 million to 35 million in 2020. And that's driven primarily, by the way, that calculation is really handled by your actuaries who it's a pretty complex calculation, a series of calculations that your actuary does, both with looking at discount rates, number of covered employees, and I know the covered employees increased by about 80 something. As I said, the discount rate, there are a variety of issues that they're looking at as they estimate what this liability is. And forgive me, I just 2 minutes on defined contribution and a defined benefit plan. It's important to maybe understand those two. A defined benefit plan, similar to what you have here through New York State, the pension is defining what the benefit is that will be paid to the individual employees. In order to do that, the actuary has to calculate what the impact will be, looking into not only salary increases, how much may be earned on the funds that are invested, the discount rate, a whole slew of things that they're looking at to come up with a way of looking at what is the present value for the benefits that we will pay this individual when they meet and retire. It's a defined benefit plan. The defined contribution plan is a much easier plan. Defined contribution, all I'm defining is the contribution I will put into that plan. I'm not telling the employees how much they'll take out of it when they turn 65. That's a defined benefit. A defined contribution is, and many businesses, 401ks, 403bs tend to be, well, we fund up to 2%, 3% of salaries. That's it. That's what goes into the plan. I've defined the contribution. I made the contribution. That's all it is. I'm not telling individual employees when you turn 65, I'm going to pay you 62% of your most recent salary. Nothing like that. Not defining the contribution, just the benefit, just defining the contribution. So when it's being done here, you have that element of it. Plus, because you do offer health insurance after the individual retires, GASB, on an accrual basis, because this is an enterprise fund, GASB requires that the liability that the individual is earning be recorded now, not when they retire and you start paying that individual or you continue to pay their health insurance. So what happens is the actuary is looking at now all your employees, looking at the what it will cost over X number of years, and there's a lot of actuarial assumptions that are used to develop what that cost is, and then they could calculate what the present value of that is, and that's what's being recorded as an expense today. So they're earning this benefit today, it gets recorded today. And when you start to look at county operated, county facility financial statements, you see these crazy huge numbers, and it's not just Valley View or Orange County or Westchester County or Rockland County, it's the entire country. So when you look at these liabilities that get recorded, and when you compare it to the salaries, if you look at 2019, for every dollar of salary, you have $1.08 of benefits. Look at 2020, because of those actuarial assumptions, how it's really bumped up. Now for every dollar of salary, you have $1.58 of benefits. And again, the benefits, it's the pension, the health insurance, the FICA, the unemployment, workers' comp, all of that. A typical skilled nursing facility, and I did a typical not-for-profit skilled nursing facility, benefits tend to run about not 106% or 108% or 158%. They tend to run about 45%, meaning for every dollar that's paid in salaries to an individual working in a New York State not-for-profit nursing home with a union, it's about 45 cents goes towards benefits. So what I did here was, again, I'm trying to say, how do you pull out this GASB adjustment, not to ignore it, because it's a fact. This is a cost, this is a liability that Valley View and the county will have over the years. But how do you pull that out to see how are we doing outside of this GASB adjustment, which is making me recognize this huge liability now for these individuals because they're working now and earning it now. So what I did was I simply said, you may recall I tried this last year. I simply said, let me see if Valley View, and again, this is like make believe, but just hear me through. How about if Valley View is not a publicly operated skilled nursing facility, but was a not-for-profit? Well, benefits would not be at 108% or 158%. It would be about 45%. So the difference in benefits in 2019 would be about $13 million lower, just employee benefits. And if you look at your loss from operations in 2019, you had about a $14 million loss. That is not including IGT. IGT is after that. I don't want you to say, oh, but you're forgetting IGT. That's operating revenue minus operating expenses, about a $14 million loss. But when you adjust it for the GASB adjustments, this 108% versus 45%, you'd be closer to, I want to say, break even. $400,000 loss from operations. Let's look at 2020. We know we've got a couple things going on here. Not only do we have the benefits increasing, but we also have census dropping. So let's look at 2020. Recalculated the benefits based on actual salaries of Valley View, $22 million of salaries. And these numbers come right from the last 2 pages of your financial statements, the audited financial statements. It's a schedule of expenses. Multiply by the 45%. So the difference in benefits in 2020 would be about $25 million. And I said, well, let's look at the loss from operations in 2020 financial statements. Again, IGT is not in this. This is simply operating revenue minus operating expenses. You have a $31 million loss from operations. But if I back out the $25 million because of this GASB, because of this 150% of your salaries and benefits, you're down to a $6.5 million loss from operations. I said, okay, that's still not good. But you know what? What did your revenue drop by? $5.8 million because of census, because of COVID. So, is this, oh, the glass is half full or half empty? I don't know how you want to look at it. I'm just trying to present, when I look at a set of financial statements, whether I'm auditing a for-profit healthcare entity, a not-for-profit, or municipal operated, I know there are differences. I know that you get IGT. Again, part of it comes, almost half of it comes from the county, but I'm not including that here. This is before we look at IGT. So my attempt here was to say, let's look at this as by kind of stripping away something that there's not much that a municipal operated facility can do. So am I saying that management's doing a wonderful job? I'm not saying anything about management. This case mix that comes into play and all the other things. What I'm saying is just looking at this, when you strip away this GASB, adjustment because of the defined benefit, with the New York State retirement system, and the fact that you pay these benefits for well after someone has retired, recognizing those expenses and those liabilities, it has such a tremendous negative impact on these financial statements. So again, I just wanted to see if this helps just maybe make a little more sense of when you look at these financial statements, say, wow, it's important that we have this. this facility. It's doing wonderful work, but look at the bottom line. How do we explain this? How do I explain this to a to anyone when I'm looking at this? So I just find this to be maybe an easier way. The reality is you've got these benefits that are being recognized now. So you can't, turn a blind eye to it. But again, before I go any further, because I'm kind of wrapping up, I don't know if you have any questions, if this helps a little, or if being that CPA that I'm trying not to be. Any questions or? And this, by the way, when I look at other municipal operated skilled nursing facilities, we see the same thing. Obviously, some of it is really driven by the actuary with the calculations. But when you start to look at there's probably about 21 skilled nursing facilities in the state of New York that are still operated by counties. You generally see the same thing. You'll see this very large employee benefit relationship to salaries that you wouldn't see with others. I will say case mix, as is mentioned before, did drop, but I know that the organization, Lawrence and his staff are working diligently on getting that case mix back up. It's tough right now when you're trying to juggle with filling beds and trying to get the census back up into the hopefully close, back up to the 90%. Any questions? Should we continue?
Mr. Chairman, Mike Anagnostakis, question.
I'm available, Mike.
Oh, okay. So yeah, thank you for the explanation. I'm on the phone and I'm trying to view this online, but basically what we're trying to talk about here is a book entry that GASB forces you to put into the financials that isn't really a cash expense on the facility. So I think another way maybe that we can kind of confirm this is if we look at the two from other funds that basically decreased, it looks to me about $4.5 billion, decreased from 57 million last year to 52.7 this year. And isn't that about the same amount that our revenues decreased because of the CPI mix?
I would think so, and I don't know, Donna or Lawrence, if you would want to add to that.
Talking about the fund balance. Oh, it's tricky.
Yeah. What he was saying there was just looking at, the due from, the funds that are held by the county.
Yeah.
I think it only went down by about $4 million. And the thought is, well, this isn't necessarily a cash outlay, this GASB adjustment right now. To a certain extent, part of it is not. We know the funding to the pension plan. Eventually, you have to fund that. But the biggest chunk of this is the OPEB, which is the health insurance. And there's no mechanism right now in the state of New York. There is no one that can fund that. I know we've had discussions with others. But Donna, that's what, I don't know if you wanted to address anything related to that. Mike, did I understand your question?
Yeah, it wasn't really a question. It was almost to say that, well, what we're trying to do is back out the OPEB that isn't a current expense on the facility. It's just a book entry that needs to be recognized because of GASB rules. And I guess if you back that out, then that huge, tremendous paper loss that we're seeing goes down to what it really is. And in a way to confirm it with you, to look at the cash, 1 year versus the other, what happened to it, the fact that it went down $4.5 million, not 30 million or whatever the GASB law indicates. That would be another way to confirm what I think you're trying to explain.
Mm-hmm. Yeah, and you have to, you'd probably also have to work into that accounts payable went up and some others, but it probably is, a quick and dirty, another way of looking at to say, yes, I could see that change. And it's a great point. I've never even thought of it that way.
It's in your presentation, Mike, on page 18. I think maybe that's where Mike Anagostakis is looking at it too, 4.8 million. You backed out the OPEB on page 18 of the presentation as well.
Yep. Okay, it was just a comment. It was just another way to look at it to make a little more sense of what the actual number is versus what the Gatsby number is.
Correct.
Right. Mhm.
Okay, thank you.
Any other legislators?
Okay, we'll move quickly then. Just page 29, if we could just jump to that. This is where we talk about, we define what internal controls are, what we look at from a testing standpoint. We did not identify any material weaknesses in internal controls. That's crucial. That's what you want to hear. We only had one observation, and Michelle had indicated this before. Each year we pick on a new area that we do a deep dive into. This year we spent quite a bit of time looking at depreciation expense, plant ledger, things like that. Our only recommendation that we see here, and it's not a significant weakness or material weakness, but it's just an observation. Like most facilities, you use an Excel spreadsheet. Each tab is the year that assets were purchased, whether it's the building, equipment, major movable, fixed equipment, leasehold improvements, land improvements, whatever. Those assets are listed on that particular tab of the Excel spreadsheet, along with the useful lives. You calculate the depreciation expense. You have a recap on the front, which pulls forward all these individual totals to a recap on the front, and that's how depreciation gets recorded. And depreciation is a fairly large number for the skilled nursing. It's about $1.6 million, and depreciation expense. That's part of the capital component, and your depreciation expense, whatever it is, Medicaid will pay you that. We know -% now, but Medicaid pays you for it. What we find with those Excel spreadsheets when it really starts to grow is you have to be very careful that because of human intervention, you may have formula errors, you may have a recap that's picking up from the wrong column, things like that. It's very common. And all we suggest here is one of two things. One, either invest in a plant ledger. They're not that expensive. And a plant ledger is basically, it's a canned program that you load up your assets, and you have great detail in the Excel spreadsheet. So you're loading up these assets, the cost, the year of acquisition, the useful life. It calculates its depreciation expense, and there's no human intervention where you're not picking up this formula, adding this minus that, moving it forward. That's one way. Or the other way is taking a deep dive yourself, looking at that spreadsheet. I know Tammy and Donna have already started doing that, and looking at that spreadsheet. And the first thing is, once you know that the formulas are correct and pulling forward, you have to password protect those formulas so that someone can't accidentally hit and delete and do something wrong. So once it's password protected, not the whole worksheet, but not only the whole worksheet, but the individual tabs and the recap, those formulas, once that's password protected, only the individual who knows the password, who understands how to do that, can make that change. It really reduces the possibility of errors. And this is not unique to Valley View. We see this quite often when you're dealing with very large Excel spreadsheets. That's our only observation. And it was just, either, again, maybe invest in the plant ledger software, or, the quick and dirty way and a less expensive way. Go back into the Excel spreadsheet, really make sure it's solid, protect those formulas. And in this particular case, if Tammy does the calculations, let Donna review it, make sure it works, boom, sign off on it, and you're done. You don't have to worry about it. So that was the only thing that we had. Any questions? I don't know if you'd want us to kind of, flip through quickly the financial statements.
Go ahead.
So I think, you know, a lot of it, we kind of already addressed. I think probably the biggest thing is when you look in the middle of the page, the deferred outflows, you know, 60-something million versus the 30s. That's where you see this huge increase in your assets and deferred outflows. Again, that's something that's unique to GASB. You would normally, if you're looking at IBM financial statements or a not-for-profit or for-profit nursing home financial statements, you're not going to see deferred outflows or deferred inflows. You'll see that the accounts receivable, patient accounts receivable up above went down. We had discussed that already. On the liability side, same thing. You have, you know, these deferred inflows. You don't see that much there, but when you go up a little above, the OPEB is the other post-employment benefit liability. That's where we see that, you know, growing from $263 million. I do know in note 10 to the financial statements is a significant amount of detail explaining the various components of these inflows and outflows. If you flip, Andrew, can you go to the next slide? Here again, this is what we were just talking about. Here is, you can see the 2019 to 2020 right in the middle, loss from operations. There's a 14 million that we discussed in 19. There's a 31 million 2020 loss from operations. Down below, there's the IGT. The IGT in 2020, not for you, but for all facilities, it wasn't a 50-50 split. The feds picked up a little more. It was probably about a 54-46 split in that range. But again, it still cost the county about 46% of that $6 million. The provider relief funds, there's that $2.5 million that you received under the CARES Act. It's relatively easy to recognize that all is revenue in 2020 because your lost revenue, you get to keep the provider relief funds if you lost revenue and the expenses you incurred related to COVID-19. If they exceed what they paid you, you get to keep the revenue. So right off the bat, we know that your revenue went down well over $5 million, and most of that we could identify, and we worked with your staff. Management already identified the loss due to COVID because your census was down. So that's been recognized. And then there's also the county charge that comes over for IT, HR, and other things. That's what's reflected here as well. So looking at the loss before any minor transfer, but it's $23 million in 2020, about almost $6 million in 2019. So that $18 million swing, as I said, you can identify it as the $5 million loss on the revenue side, the $11 million of additional expenses, kind of gets you to this change in bottom line. If you jump to, I'm trying to think if there's anything new in the financial statements. I know Michelle had identified note 12 addresses. So what the organization will do, the Department of Health and Human Services, it will be opening the portal up, and Donna and Lawrence and the staff will load up financial information to document how they spent the $2 million in CARES Act funds. That'll be a combination of loading up the revenue so they can see the lost revenue, the additional expenses incurred for supplies, PPE, some salaries, whatever the additional costs related to COVID. That portal will be open. You'll have from July 1st for 90 days to upload that information. Eventually, we will have to conduct a separate audit just on those funds. And that's the one that, we had indicated early in the beginning of the presentation. That audit is not due until March 31st of 2022. But I assure you, none of us want to be auditing 2020 information in 2022. We'd like to get that over soon. So from an audit standpoint, the portal gets open. You start to upload the information. We are waiting as practitioners, as CPAs, waiting for final guidance on what they want us to perform from an audit standpoint. So this uniform grant guidance, there are certain things, very specific issues that they'll probably want us to look at. It's basically looking at, I had my notes here. I've been flipping so many pages, I apologize. It's basically looking at Was the expense incurred necessary and reasonable to support patient care efforts to prepare for, prevent, or respond to coronavirus? So that's kind of, it's a very broad description, but those are that's the expenses that your staff have been tracking. That's what we'll look at, the tracking of that, looking at the lost revenue. And that separate audit will be conducted. We'll upload that. And as I said, we want to finish that well before March of 2022. If during the course of that audit, if we came across something that we wanted to report to you, we would let you know. Well, management would let you know also immediately. But we're not anticipating any changes to the financial statements. From what we could see, you've earned that $2.5 million in CARES Act funding. Any other questions?
Any legislators?
If not, again, we really do want to thank, Lawrence, Donna, Tammy, and the rest of the staff at the facility. And also, some of the audit work that we perform, we rely on our government practice who's at the county working on the county audit. So we want to thank the county employees as well, because indirectly we get that benefit because we get to use that information at the county audit is our county team. Chris Coffin and his team, we get to use that as well. So we really do appreciate, they're working with us during really a difficult time. So, and I sure hope next year, Lawrence, Donna, and Tammy, we're sitting in your office without masks.
So do we. Well, okay, thank you very much. I appreciate it.
Great. Thank you, everyone.
Yeah. So that clears the table. Do I have a motion to adjourn?
So moved, Tortel.
Thank you. Seconded by me. Everybody have a great evening. Thank you very much.
Thank you.
Thank you.
You too. Bye-bye. Thank you.